In interventional oncology, a successful procedure often produces an initial follow-up scan that looks like a failure. Immediately after a tumor is destroyed, the resulting lesion typically appears larger and more prominent on imaging than the original mass. Misinterpreting this expected evolution can lead to patient anxiety and the performance of unnecessary repeat procedures. Understanding these scans requires an analysis of the thermodynamics behind the three primary ablation modalities: radiofrequency, microwave, and cryoablation. By mapping these physical interventions to standard multiphase CT and MR imaging, clinicians can differentiate expected physiological healing from residual cancer. Managing these cases effectively involves connecting the energy delivery in the procedure room to the specific pathology seen on the monitor months later. Radiofrequency ablation, or RFA, is governed by size. For curative intent, the tumor must be under 4 centimeters. Larger lesions shift the goal to debulking. A curative result requires ablating the entire tumor plus a 0.5 to 1.0 centimeter margin of healthy tissue. This margin requirement dictates patient selection. A critical structure within 1 centimeter of the lesion is a contraindication for RFA. High-risk structures include the vascular hilum, the gallbladder, and loops of bowel adjacent to superficial lesions. RFA generates heat to induce tissue necrosis, with a target temperature of approximately 60 degrees Celsius. Temperatures exceeding 100 degrees Celsius cause tissue carbonization. This increases electrical resistance near the probe, preventing heat from spreading and resulting in an incomplete treatment zone. Because the procedure relies on an electrical circuit, it requires a grounding pad on the patient's leg and insulation between limbs to prevent arcs or burns. RFA is an effective tool, but its utility is limited by the proximity of vulnerable anatomy and the physics of electrical conductance. Adjacent vasculature represents a significant challenge to thermal ablation. This is the heat sink effect. When a vessel 3 millimeters or larger is adjacent to the target, moving blood carries thermal energy away from the lesion. This cooling prevents lethal temperatures, often leaving viable tumor cells along the border. Microwave ablation provides a technological alternative to address these thermal limitations. Microwave systems generate higher power and can create larger ablation zones in less time than RFA. This modality is less susceptible to the heat sink effect and does not require the use of grounding pads. By utilizing electromagnetic waves rather than electrical current, microwave ablation maintains thermal efficiency near major vessels. Cryoablation shifts the mechanism from heat to extreme cold, using ice formation to destroy the target. This technique uses compressed argon gas. These systems create rapid freeze-thaw cycles. While freezing is visible on imaging, the thawing phase primarily kills cancer cells through cellular lysis. Cryoablation is generally less painful for the patient than thermal methods, often requiring less sedation. However, it carries a higher risk of bleeding because the cold does not cauterize small vessels as heat does. This requires a specific procedural sequence when a biopsy is needed. The probes must be placed first, followed by the biopsy, and then the treatment. Performing the biopsy before probe placement can cause hemorrhage that obscures the imaging, making it difficult to position the probes accurately. Cryoablation offers distinct advantages for patient comfort, but it requires precise coordination to manage the lack of hemostasis. Once the procedure is over, the focus shifts to interpreting the post-treatment imaging timeline. Between weeks 1 and 4, an ablated lesion normally appears larger due to reactive edema. By month 3, it should return to pre-treatment size or smaller. At 6 months, progressive shrinkage is expected. Any increase suggests recurrence. While size is a factor, contrast enhancement is the primary indicator of clinical success. Standard diagnostic criteria state that central or peripheral enhancement inside the ablation zone is never a normal finding. You may see benign peri-ablational enhancement. This should appear as a smooth and uniform ring around the periphery of the ablation zone. If the enhancement is scattered, nodular, or eccentric, it indicates the presence of residual tumor. Malignancy is suspected when there is an enhancement change of more than 10 Hounsfield units compared to the pre-contrast scan. Clinical management depends on prioritizing these enhancement patterns over the initial changes in lesion volume. In the days following the procedure, patients may experience post-ablation syndrome. Low-grade fevers and body aches are common responses to tissue necrosis and typically require only supportive care. However, a fever that persists for 2 to 3 weeks warrants an infection workup. Accurate communication with the oncology team requires the use of standardized nomenclature in radiology reports. The terms residual tumor or incomplete treatment are used when focal enhancement is seen on the first post-therapy study. Recurrent tumor is the appropriate term if new focal enhancement appears on a later follow-up study. If the multi-phase imaging at 1 month confirms the presence of residual disease, the standard next step is to immediately plan a repeat treatment. Effective interventional oncology pairs the physics of the probe with a protocol-driven interpretation of the follow-up scans.